Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. It's our pleasure to welcome you all on our first lecture in Breast Ultrasound Lexicon, Interpretation and Management. Please join me in welcoming our host, Dr. Rabab Muhammad, Consultant Radiologist. Thank you so much, Dr. Rabab, for your time and effort. And we are looking forward to benefit the most from this new series. You may start your lecture now.
Thank you very much, Nauras. بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين حبيبنا ونبينا محمد وعلى آله وصحبه وسلم وببركته موفقين بإذن الله. Hello everyone. I'd like to welcome everybody for our today's session. Are going to start a new lecture series discussing breast ultrasound interpretation and management based on the ACR lexicon. Again, it's like Sarah. Okay. As you know, mammogram is the mainstay, and high resolution ultrasound is a second chair in the orchestra of diagnostic breast imaging tools. And along with mammography are the conventional modalities increasing the diagnostic accuracy and also now playing a role in screening. Our lecture's goal is to discuss breast ultrasound present features, categories, and descriptors, help the interpreting radiologist with the following: to assess possibilities for feature analysis for various clinical scenarios, predictive features of benignity, predictive descriptors of cancer, and management recommendation categories, as well as management of certain clinical scenario throughout the series of the lectures. In 1993, breast imaging reporting and data system was developed by the American College of Radiologists, ACR, to standardize the language for reporting mammography and to facilitate communications between clinicians by clarifying mammographic interpretations. The ACR recently developed a BIRAD lexicons for ultrasound, and the first edition was published in 2003, BIRAD's Ultrasound Lexicons by American College of Radiology. That was updated in 2013, the fifth editions, and the second update, or the latest update, was in 2023. But up to date, I have no, I couldn't find these editions. Have you have any copy of this, the latest editions? Any of you? Any of you can, or he got that editions or not yet? Okay. As you know, the lexicons start with breast compositions, and we have already discussed before that the breast compositions on ultrasound, and then describe the mass. And the descriptors of the mass include shape, margin, orientation, echo pattern, and posterior features with more further descriptors. Then the other item is the calcifications. We are not going to discuss these in these lectures, the associated features and special cases. Today, we are going only to discuss the mass. Although the breast imaging or reporting system for ultrasound is based on the breast imaging reporting data system for mammography, there are some differences between the two lexicons. First of all, the asymmetry is a unique descriptors on mammographic lexicons not seen or not used in ultrasound lexicons. Also, the mass density, okay, used on mammography is not used in ultrasound, and the architectural distortion is the main descriptors on mammography. However, in ultrasound is considered to be an associated features. Regarding the mass descriptors, the orientation, echo-pattern, posterior features are ultrasound unique descriptors. We cannot use it on mammography descriptions. The calcifications. On mammography, it is a big entity. Yeah, because mammography is the best modality that demonstrates the calcification. That's why we can see detailed descriptors regarding calcification in the mammography lexicons, while in ultrasound lexicons, the calcification has limited descriptors, just calcification in mass, outside the mass, and intraductal calcifications. And the axillary adenopathy. On mammographic lexicons, axillary adenopathy considered to be an associated feature, while on ultrasound lexicon, lymph nodes or axillary lymph nodes considered intramammary as well as axillary lymph nodes considered to be special cases. There is also, or there are more descriptors in associated features belong to ultrasound lexicons or are special to ultrasound lexicons not included in mammography lexicons, which are the Doppler vascularity and elastography. Okay. The definition of the mass is the same in all modalities. The mass is a three-dimensional lesion that occupies space. So, supposed to be identified in two orthogonal views or projections, okay, in 2D, and has at least a partial convex border, okay? Masses on ultrasound should be seen and evaluated in at least two different planes, but it is better to be evaluated in three different planes. According to the ACR, there are basically four morphological descriptors of a mass on ultrasound. These descriptors include shape, margin, orientation, echo pattern, and posterior features. Okay, regarding the shape, there are three descriptors: oval, round, and irregular. Lobular, previously used, now is discarded. No more use the lobular shape. What is the oval shape? The oval shape is elliptical or egg-shaped. When we look here, this is an oval. So obviously the transverse diameter or dimension is elongated, is long. It is the long axis of the lesions, okay? The longest or the greatest dimension is the transverse dimensions. That is why it is oval, you see? And generally, it is, as we mentioned, it is larger than the AB dimensions. And when the lesion or when the mass is oval, that means it has a regular shape. That means most likely it is a circumscribed. Then it has a negative predictive value of 84%. You see, the probability of being cancer is low. However, if it is associated with parallel orientation and circumscribed margin with a thin pseudocapsule, the negative predictive value increase up to 98 to 99%. So the probability of cancer then will be very low. It will be very reassuring. They consider two or three large undulation, gentle lobulations. What is called macro lobulations is part of oval descriptors. Previously, they describe it as lobular, but now it is just included under the descriptor of oval shape and has the same predictive value of the oval shape. However, if you look for these examples, the three of which are oval shape, but what is the difference between the three? This one, it looks flattened, is not bulging, while this a little bit is oval. These are oval, but a little bit the anteroposterior dimension is a little bit close to the transverse dimension, giving a ratio of less than 2. According to Stefros, he subclassified this oval into oval flat and oval plump. And he considered this one is much more reassuring compared to the oval plump shape for the prediction of malignancy. Okay, what is the difference between this and this mass? When we look here, it has gentle to undulation or macro lobulation. But when we look for this one here, we can see more than 3 lobulations. More than 3 lobulations. So this is strictly oval. According to the ACR descriptor, we can say confidently this is oval shape. But when we look for this, we can say roughly it is an oval shaped mass. Why? Because it's not closely, it's not strictly under the definitions of the oval, because it has more than, they mentioned that to consider it oval, allowed to have 2 to 3 large undulation, large cycles, undulations. But here I have more than that. So in such case, as a radiologist, I will try to analyze these lesions and I can put it in a phrase. You see, I have to describe it in a phrase. Not just to say, this is oval shape and that is it. And this lesion was biopsied and proven to be a fibroadenoma. Okay, what about this lesion? What do you think about these lesions? How you are going to label the shape or to describe the shape of this lesion? Any suggestion?
I would describe it as roughly oval.
What?
I would describe it as roughly oval. It has more than
Roughly
three.
oval.
Yeah,
Roughly
more than.
oval. It's
Mm.
okay. This is your suggestion. Do you agree with her or disagree? And why?
I will describe it as irregular.
Excellent, sir. You describe as irregular. Why you describe it as irregular?
It has more than 3 undulations and some micro-undulations periodically.
Sorry, I
But
couldn't recognize your voice. May you
okay.
again?
It has more than 3 undulations and
When?
and there are small micro-undulations periodically.
Excellent. Excellent. What else? Yes. You are right. Yes.
So
I cannot consider it like that one. Why? Because as Sarah said, this lesion is irregular. Apart from if the undulations are more than 2 or 3, more than 3. Okay. Not only that, there are some large and some small undulations. Okay. Not all the same. This is one issue. The other issue, there are other suspicious features. So supporting that to consider these lesions as an irregular shape rather than just roughly oval. Why? It is non-parallel orientation. The margins I can see here, yes, anteriorly it is circumscribed. I can see it sharply here and even this. But what about here? The margin here are not sharp, are not clear. This is when there is here cutoff of tissue plane adjacently. And even here, there is some thickening, hyperechoic thickening focal area of echogenic rim or rim here. So, and there is mixed posterior and posterior enhancement and shadowing, and there is significant intravascular intramass vascularity. So all features are suspicious. When I compare it with these lesions, this is parallel. It is slightly or gently hypoechoic toward isoechoic, while this is deeply hypoechoic and some heterogeneity. It has some heterogeneity. Here, more hypoechoic than this area. It is heterogeneous, while this is homogeneous. Here I can see throughout, you see, anterior, posterior, and even lateral, I can see thin pseudocapsule. That is why in such lesions, this is more reassuring, but this is suspicious lesion. Though here, it give appearance that it might be irregular, but not all other features are more reassuring, but we have to put it as BIRAD 4A, you see, and to recommend biopsy to make sure that it is really benign. Although that we are going more toward benignity, but since it is atypical, we have to recommend biopsy. Okay, this case, these lesions, that was proven fibroadenoma, but this one was breast metastasis. The round shape. What do you think about the round shape? Is it reassuring or not reassuring? It is a regular shape. Oval and round are regular shape. But the difference between oval and round, what is the difference? The round is a ball shape, is a circular, is a globular, okay, shape. And to call it round, it has to be circular in two orthogonal projections. In both, it has to be circular with anteroposterior and transverse diameters are equal to call it a round lesions. Though it is not common findings on ultrasound, when it is soft tissue or solid, is not a reassuring signs. It is not a reassuring signs, okay? And sometimes the round complicated cyst can be challenging to be differentiated from a soft tissue or a solid round lesion. So it is not reassuring, as we said, unless it is a simple cyst. If it is a simple cyst, rounded simple cyst, then it will be reassuring. Otherwise, we have to consider it as suspicious findings if it is soft tissue. Okay. What is the shape of these lesions? So obviously
irregular.
Obviously not oval, not rounded. So since it is not oval, not rounded, are irregular.
Yes.
Okay. A feature more suspicious, though there are many benign pathology presenting as an irregular mass like white necrosis, complex sclerosing, radial scar, surgical scars, mastitis, diabetic myostopathy, and hyalinized fibroadenomas, fibrocystic changes, and so forth. But since it has a positive predictive value of 62%, so it is in the range of BIRAT 4C. The only irregular shape, the only features corresponding to BIRAT 4C, any irregular lesion, unless proven benign, it has to be BIRAT 4C. Okay? Here we can see more examples of irregular shape. All of these are proven to be breast cancers, okay? All are irregular. Okay, let us go and describe another features of masses on ultrasound is orientation. Orientation is defined with reference to the skin line, and it is a unique descriptors of auto ultrasound. Okay, descriptors only used on ultrasound, cannot be used on mammography or MRI. And it should not be considered as a sole feature when assessing for the likelihood of malignancy. This is cancer parallel, and these two cancer, this cancer not parallel or not parallel, and this is a benign lesion not parallel, which is radial scar. Okay, talking more about the orientations. What is the orientation? Generally, we are looking for what? What is this? This is the first one is the long axis. This is the long axis of this mass, and this is the long axis of this mass. What is the long axis? Is the longest dimensions for the mass, or the greatest dimension of the mass. Here, the greatest dimensions of the mass is the transverse. while this one, the greatest dimensions is the vertical one, is the anteroposterior one, okay? So since the greatest dimensions for this is the anteroposterior, it's perpendicular to the skin line. So this is a non-parallel mass, okay? This is a non-parallel mass, and historically called taller than wide, or a vertically oriented mass. No more use, neither taller than wide or vertical. Now the descriptor is a non-parallel orientation, and this being non-parallel is a suspicious features with a positive predictive value for cancer is 69%. So still, again, this in the range of BIRAT 4C. Any mass oriented non-parallel, it is BIRAT 4C. What is parallel? Parallel, the long axis or the greatest dimensions of the mass, parallel to the skin line. This is parallel to the skin line. Previously called wider than tall, or horizontally oriented. No more use. Now they are using parallel descriptor and usually suggesting benignity, okay, or benign etiology with a negative predictive value of 78%, okay? However, so still I have 22% probability of being malignancy. But if it is associated with oval shape, and definitely it is an oval shape, being parallel, it is an oval shape. But if it is circumscribed with pseudocapsule completely seen, pseudocapsule, then the negative predictive value will raise up to 98 to 99%, and so it will be within the range of BIRAT 3. Still not BIRAT 2, BIRAT 3, okay? Okay, tell me what is the orientations of these masses? Give me the orientations for this one, and this one.
The one at the left, round it. This is not parallel.
Sorry, I could not. I couldn't hear you. I don't know the problem in the mic or in the
problem in my voice.
You have problem. Sorry for that. Sorry to hear that.
Okay. If you mean number one, this is parallel.
This is parallel. Okay, why it is parallel?
Because it's
though it's slightly oblique, but why it is parallel?
Because it's longest diameter, or its transverse diameter more than
it is not. It is not exactly parallel to. Yani, if you draw the longest dimensions, it will be like this. It is coming like this. Okay, and the skin like this. It is not exactly parallel. The longest axis is not exactly parallel to the skin. So, and the same for this one. Same for this. If we draw here, the line, it is not parallel to the skin. It's coming slightly oblique. So
still it's an oval lesion and
still, yes, you are right. Still what?
it's an oval lesion and with regular margins and well-defined pseudocapsule. So I will put it by MyRat 3.
Yes, okay. I'm talking regarding the orientation. How you are going to label it, okay? To label the orientation of this lesion, or to classify the orientation, or to describe the orientation. What is the descriptors regarding the orientation of this lesion?
Parallel.
Who said parallel?
13.
Excellent, 13. All the three are parallel?
لا، اللي قاعد نتكلم عنهم الأوفال شيب.
Excellent. Excellent. Parallel. Agree with you. Why are parallel?
يعني الزاوية يعني أقرب إنها تكون.
Excellent. Well done. Excellent. Well done. Yes, you are right. You are right. Because they are still closest, okay, to the parallel, not toward the anti-parallel. If we draw the angles, as she said, it is more closest to the and what about this one?
ما حقدر أقول بررل وما حقدر أقول not بررل.
Why?
لأنه هو round shape يعني ال AB diameter و transverse diameter almost equal.
Excellent. Who is talking?
13.
Excellent, 13. You are right, 100%. So there are theories regarding that issue. Okay? As you mentioned, regarding the rounded, the longest, it has no longest axis. The AB equal the transverse. So consider it as non-parallel, because previously we mentioned that being rounded is a suspicious feature, is not a reassuring feature. So they are not going toward the reassuring descriptors. They consider it as a non-parallel lesion. If you have a round lesion, regarding the orientation, you are going to describe it as a non-parallel mass. Okay? That clear? Is that clear? Okay.
Yes.
Rounded, non-parallel. Full stop. What about this one? And this one? Both are obliquely oriented. And this one also obliquely oriented. What is the difference between the three? The three of which are obliquely oriented. How you are going to describe the three of these, each of these three masses regarding orientation?
In the left image, it is not parallel.
Excellent, not parallel. Why?
Because it is يعني أقرب لأنها تكون not parallel من إنها هي parallel.
Excellent, because if you look for the long axis, it is more oblique. يعني the obliquity is much toward the vertical, going more near to the vertical rather than horizontal. This one, the obliquity approaching the vertical rather than horizontal, while this one, the axis approaching the horizontal more than that is why here, that is the explanation. You have mentioned it, tertil, okay? But you did not explain it very clear because the long axis here with the angles acute with the horizontal one. It is more toward the horizontal, and the same for this one. Okay? And again, here, this is more toward the horizontal, but this is the long axis approaching the vertical. So I'll consider this as a non-parallel. Along with the other suspicious features, make me that I have to consider it as non-parallel. But what about this one? Can you tell me? What is specific features regarding these lesions? Regarding its orientation. What is the location of this lesion?
The axilla.
Why the axilla? What is this?
This is not.
Huh?
This looks like lymph node.
No, this is breast, and this is duct, and here this is the nipple. Okay? We are talking about orientation of a breast mass. So I said, where is the location of these lesions? Is in retroareolar. Okay? So regarding what is the rule regarding the retroareolar lesions? Talking about the orientation. When you talk about, we have discussed it before. We have discussed that issue long time in our courses regarding the orientation of retroareolar regions. We have mentioned that the ducts are crowded and pointing toward the nipples, and most of the lesions are arising in retroareolar, arising in relation to these ducts. So you expect the lesions on retroareolar, okay, to be along the radial directions. Okay, so expected benign appearing lesions, retroareolar, okay, to have a radial direction or obliquity, and you will consider it as parallel. By definition, you will consider it, but if you might see a suspicious lesions or not parallel in retroareolar, you should not call it a parallel lesion unless it is a circumscribed oval lesions obliquely oriented in the retroareolar region. Then you can call it as, or you can describe it as a parallel lesions. Okay, if the lesions away, as we have mentioned earlier, then we'll go and see the long axis of the mass and its proximity to the horizontal or the vertical axis. Obviously here, this one more toward the vertical, while this more toward the horizontal. Okay.
يا بس
as I
الريتروأوريولار ما وضحت إنه كيف أقدر أقول برر ولا not برر.
okay, I'll explain. Okay, this here we have examples, two examples of retroareolar lesions. This one is obviously seen intraductal, and as we mentioned that the ducts are radiating, you see, crowded and pointing toward the nipple in a radial direction. Do you agree with that in the sonographic anatomy?
Yes.
You see, being the ducts pointing radially toward the nipple, so you expect the benign lesions to have the same directions, to be obliquely oriented. So being there is explanation for the orientation of a benign lesion in that directions, then we consider it as a parallel. But it is not always the case. If there is a suspicious features, like in this case, okay, this is not very typical benign, it is borderline, okay, in retroareolar, I'm not going to call it as a parallel lesions. I'm not going, since I have suspicious feature, I'm not going to search for reassuring features. Because you know that we usually seek for any malignant or suspicious feature to be to evaluate the breast mass and to exclude malignancy. If we have any suspicion, we'll go toward the suspicious features. We will not go toward the benign features. Okay? Is that clear? This is a DCIS. It is obliquely oriented, okay? Toward the nipple. This is the nipple areolar complex. It is obliquely, but it is indistinct. And there is internal vascularity, okay? And it was proven to be a DCIS. I'm not going to call this as a parallel lesions. Is that clear, 13?
Yes, yeah, boss. واضح.
Okay. Okay. So, as we mentioned earlier, orientation should not be used as a sole feature in assessing a mass for the likelihood of cancer. If you look, these my patients, these are my patients, this one, okay? While this from the literature. This from the literature, they reported as a benign mass, proven benign mass, but look, the orientation is vertical. And here, this is invasive cancer vertical. This is my patient, invasive, proven invasive cancer, is small cancer, is vertical. But these are horizontal. These two are horizontally oriented, also invasive cancer. This is my patients. This from literature, and this is my patients. Both are proven to be invasive cancer and oriented horizontal or oriented parallel, okay? And these lesions is a parallel and in retroareolar. So not all retroareolar mass is supposed to be oblique or non-parallel in orientations, okay? What is the theory behind this orientation of ultrasound masses? There are many theories regarding that mentioned in the literature. Lack of rotation of fixed malignancy, growth across tissue plane, only measuring central nidus, and so forth, compressibility of malignancy. But the most, suggestive theory is reflection of axis of orientation of the TDLUs in which a small cancer arrows. Do you remember this image or these illustrations before? When we describe the anterior and posterior and the terminal TDLUs, and when mentioned that why the lesions parallel and non-parallel, the cancer seen as parallel and not parallel. Do you remember that? Any of you remember that discussion?
Yes.
Mm-hmm.
Yes.
In the anterior and posterior.
Swear?
Then, yes,
Oh, I'm happy to hear your voice. Huh?
in anterior, now I can share.
Yes,
In
thank you.
anterior and posterior, the mass, it is not parallel to the, it is not parallel in orientation.
Excellent.
But, yes, because the terminal one, the terminal duct, the mass arise in the terminal duct. It looks not parallel.
Excellent.
Sorry, it looks parallel, and the shape will be rounded in the terminal. The mass arise in the terminal duct. So if the mass,
which terminal duct lobular unit giving an unparallel, and which one giving a parallel? To make it short.
Yes, the parallel, the parallel at the terminal duct. Okay.
Excellent. The terminal lobule. This is a terminal lobule of terminal duct lobular unit. Usually,
the mass arise here.
Yes, demonstrate a parallel
mass.
While cancer, we are talking about cancer now, because the benign have a different appearance and something like that. But regarding the cancer, and the anterior and
posterior lobule, here the cancer arise is not parallel to the skin. It is oriented deeply.
Excellent. Okay. So as we have mentioned earlier, you see, the extralobular terminal duct in the anterior a bit longer than the posterior one. Do you remember that? So we expect, what do you expect? The cancer in the anterior compared to the posterior. What will happen? What do you expect? Which one will hit the main ductal system first?
The posterior one.
The posterior. You see, the posterior very soon, because of the short term extralobular terminal duct, very quickly it will infiltrate the main ductal, or it will hit the main ductal system. But this is the anterior one, it will take longer time. So you expect to see larger mass here before getting involved the main duct. And if you look here, you see, this is the lobule, and that is the extension pointing toward the ductal system. It gives you that appearance. Okay, this appearance. It demonstrates that cancer arises in an anterior terminal duct lobular unit. But if you look for this, it seems to be the reverse. You see, it's pointing up like this one. You see, this is cancer arise in the posterior terminal duct lobular unit, and then extend in the extralobular terminal duct going toward the ductal system, and they said that it's like it seems to be like a tennis racket. You see, they are giving a simulation of a tennis racket. And as we mentioned, that cancer arises from the posterior, hit the main duct soon because of the short extralobular terminal duct, rather than, or compared to the anterior one, will take a longer time. If you compare here, this is the anterior, the shape of the anterior, and that is the shape of the posterior. This is from the literature. This is from the literature. This is my patients, and this is my patients. Okay. Look for this one here from the beginning. It's still small. Okay, but it is, if you look here, the transverse dimensions is larger or is greater than the anteroposterior dimensions. So it is horizontally oriented. It is parallel. But it is obviously, if we look here, this is, can you see the segmental duct and the extension here? So the tumor extended through the ductal system and it arose from the terminal duct lobular unit. And according to Stefros, they said that the cancer arise from terminal duct lobular unit never be taller than wider because of transverse orientation begin with. Okay, so in conclusions, the non-parallel orientations due to cancer arise from anterior or posterior, and the shape of which, okay, depend on the terminal duct, if it is anterior or posterior, and the extent through the terminal duct lobular unit. Now you can understand the importance of the sonographic anatomy. Understanding the sonographic anatomy, how it helps us to understand the interpretation and the pathology. Okay, and this one, it was proven invasive cancer with extensive DCIS, or it was extensive DCIS with invasive cancer. Okay, but these features, what we have described, you see, it is not always present. Why? Because when the cancer become largest and is spread, it might spread horizontally, okay, more than vertically, and it can change. So when we talk about these features, we are talking about small cancers. So we can see largely if the cancer in 10 millimeter lesions, okay? But when getting large, the probability of seeing this antiparallel and this tennis racket appearance and the reverse one is difficult to be visualized. If you see here, look for these are a little bit small, so you can visualize it. But look for this one now, is the big lesions, we don't know how it started. Okay, it was like that, or from the beginning it was horizontal. Okay, let us go for descriptors of margins. Okay, the descriptor of margins, it means that the edge of or the border of the lesions, and it is important predictor, very important predictor of a mass. It is the primary predictor for the mass to be benign or malignant. And there are two main descriptors regarding the margin: circumscribed and non-circumscribed. Circumscribed, that means a well-defined with an abrupt transitions between the border of the lesions and the surrounding tissue in the entire margins. Important, this is important point. Throughout the margin, entire margin supposed to be well-defined and abruptly transition. Okay, from the surrounding tissue. Non-circumscribed, if there is any part of the lesion, the whole part or any part of the lesions, okay, is not circumscribed, is not abruptly well-defined, there is no abrupt transitions in a focal area or the whole area, and or there is area not well defined. Okay, and the non-circumscribed is suspicious, and it's subdivided into indistinct, microlobulated, angular, speculated, or combined. And if we look here for these illustrations, there is abrupt is well defined. You see, throughout from the surrounding tissue, there is well-defined margin, abrupt transition between the margin of the mass and the surrounding. And as you have seen it here in this fibroadenoma. But in this here, we can see a transitional zone between the lesions and the adjacent tissue, as is seen in these illustrations. Okay? And we should not describe the non-circumscribed margin as irregular margin, because the irregular descriptor of a shape should not be used instead for non-circumscribed margins. Okay. Regarding the circumscribed margins, as we mentioned that circumscribe the boundary, abrupt interface between the lesions and the surrounding tissue. It is well defined throughout entire margins, okay? Well demarcated, smoothly marginated, historically called well defined, sharply defined. No more use. Now the descriptor is circumscribed, okay? And classic is a simple cyst, as you have seen here. It's classic simple cyst. And this fibroadenoma with a pseudocapsule seen completely throughout. This is very important. Okay? A thin echogenic line. The pseudocapsule, when seen, okay, it has to be seen completely. And in such case, it will suggest a benignity, more in favor of a benignity. But at the end, it is a non-specific features. But circumscribed descriptors has a negative predictive value of 90% per se. If the lesion is circumscribed, sharply demarcated, smooth throughout, it has negative predictive value of 90%. And when associated with oval shape and parallel orientation, the negative predictive value will be up to 98 to 99%. So it will be within BIRAT 3. Okay. Sorry for that. I think this is the doubling of the slides. I have to remove this, but I forget. Sorry for that. Okay. Here we can see pseudocapsule. This is a pseudocapsule, and this is a 2 fibroadenoma. What is the pseudocapsule? Pseudocapsule is a thin hyperechoic uniform line surrounding an oval parallel mass. This, it has to be oval, it has to be parallel, suggesting benignity, okay? It is thin, it has to be thin, uniform, and complete. Okay, we have to look. Generally, we can see it clearly anteriorly and posteriorly, but we have to make sure on the lateral aspect of the lesion. We have to see it on the lateral aspect of the lesion. Here we can see it, sorry, the arrow move. We have, this is supposed to be here. Excuse me, let me bring it here. Okay. So here we can see anterior and posterior. In these two examples, the pseudocapsule is seen completely. According to Stefros, the pseudocapsule should surround the mass completely to label it as bara 3, as probably benign, especially the side walls of the lesion where lower resistance between the tissue plane. It has to be seen or it has to be visualized, and usually the resolution is good anterior and posterior, but the lateral or the coronal planes of the lesion usually technically challenging, but we have to angulate our probe and do a lot of effort to visualize these sites, you see, and to overcome the technical limitations. Why? Okay, to see the capsule at the sites to avoid false negative results. Okay. Okay. What about the margins here? Is it circumscribed? Is the margins here circumscribed?
No.
This is
No.
okay. This is indistinct margins. Okay, this is, we call it indistinct. The descriptors for the margin here is indistinct. There is no abrupt transition between the mass and the margins. While both these are invasive cancer, both are my cases. This from the literature diagnosed to have sclerosing adenosis. Also, though it is benign, but it is having or it has indistinct margins. What is the indistinct margins? Okay, it is a subcategory of non or not circumscribed margins. It refers to having no clear demarcation. There is no clear demarcations, either partial or complete throughout the margins from the surrounding tissue. The mass from the surrounding tissue would not be seen well demarcated. If you look here, this is my patients, this is my patients, these two, both are breast cancers, a heterogeneous mass, but it is really difficult to differentiate it from the adjacent tissue. And this from the literature, also the boundaries of the lesion are not clarified from the adjacent tissue. So this is either completely or partially not demarcated or not distinct sharply from the adjacent tissue, then it will be indistinct descriptors for the margins. And these include the echogenic rim, historically called halo. Okay, the echogenic rim, historically called halo. Okay, and so before talking about the echogenic rim, let us talk about the indistinct descriptor itself. In the past, the descriptor for corresponding to indistinct was ill-defined or poorly defined, and now are no more used. No more use the ill-defined or poorly defined. Okay, and indistinct is a suspicious features, okay, for malignancy. And as I mentioned, include the echogenic rim, historically called echogenic or echogenic halo, which is no more use. No more use the echogenic halo. In the 5th edition, they replace it by echogenic rim and expected to appear in the 6th edition the echogenic rim rather than echogenic rim. Okay? So if you said now echogenic rim or echogenic rim, so this it means the echogenic, okay, this corresponding to this hyperechogenicity surrounding the lesions. You see, this is this image from the literature, from old, it looks to be, it seemed to be old because they label it here as echogenic halo. You see, that is the echogenic halo, no more used, no more used echogenic halo. Now it is echogenic rim or rim, not necessarily to completely surrounding. Here, if you have seen here, it is partially surrounding these lesions. And also this one, partially surrounded by hyperechogenic. This is my patients, you see, this oval parallel, but it is indistinct and surrounded by a relatively thick hyperechoic layer, making the lesion indistinct. So the positive predictive value of these descriptors, the echogenic rim, is 74%. So if you have seen these signs, that means these lesions supposed to be in the range of, or it has to be graded as BI-RAT 4C. Okay. Again, talking about the echogenic rim or echogenic rind. It varies in thickness. Look for this one. You see the thickness of this one, compare it by this and compare it by this here. The lesions, the needles of the cancer needles, hypoechoic needles, is small compared to the surrounding echogenic rim or echogenic rind. So it is a thick band of various degrees of echogenic tissue surrounding all or part of the mass. Okay? But if you look for the tissue, surrounding tissue, it disrupts that tissue. That means it is associated with architectural distortion. And it's thought to be represent a desmoplastic reaction or a peritumoral edema or spicules that are too small, okay, to be resolved sonographically. And in some machines, high quality machines, they might compare lesions with this echogenic rim from a low quality machines and demonstrates such speculations, okay? This, as we have mentioned, it has a high predictive value, 74% for malignancy, and therefore warrants biopsy until proven benign. Why? Because it is a notable exceptions in a fat necrosis. If it is proven this is a fat necrosis, then no need for biopsy. Otherwise, it has to be biopsied. Okay. What is the difference between this and this? Both are echogenic. What is the difference between the pseudocapsules and the echogenic rind or echogenic rim? Okay? So obviously, the pseudocapsule seen associated with usually fibroadenoma or with the benign lesions. It is thin, it is uniform, it is complete, surrounding an oval parallel mass. So going toward the benignity, as you have seen it here. This pink arrow, you see, demonstrate this is a thin pseudo capsules. And you have seen it here in the illustration throughout complete. This is a pseudo capsule. But what is the echogenic ring as we described? But here, if we compare it with the pseudo capsule, the echogenic rim thicker. Both are hyperechoic. Both are hyperechoic. But if you look for these adjacent lesions, the pseudocapsule seen anterior and posterior here is thin, while the rim is thick. This is uniform, even here more obvious in the illustration. Thin throughout, uniform thickness. This one is irregular or varies or variable in thickness, surrounding a mass of any shape. This surrounding oval parallel. It has to surround an oval parallel, but the rim surrounding a mass of any shape, and it is associated with distortion, as we have mentioned. You see? Can you see it here? And usually thicker at the edge. You see? Look, if you look here for this one, anterior and posterior, but look, see it here. Look for this one laterally. Look for the thickness of the hyperechogenicity. You have seen it here, how it is thick laterally compared to anterior and posterior. And even here, look for the hyperechogenic rim here anteriorly. And this is all the thickness laterally. So in the lateral aspect, usually it is thicker. Okay, these are examples of oval parallel masses surrounding by pseudocapsules. Okay, I have to make sure here the image is not complete. I should not pass it like that. I have to look real time to make sure the pseudocapsule intact in the lateral aspects. And again, for this, I have to make sure, yes, it is intact throughout, but I should not pass it. I have to make sure both lateral aspects, it is okay. And the same for this one. When I'm looking here, I have doubt about this edge. See, it looks like as if it is interrupted. I have to clarify this and to make sure this pseudo capsule is complete throughout, especially on the sides of the lesions. These are pathology proven fibroadenomas, but if you look, neither of which having complete pseudocapsule, though some are parallel, homogeneous, and oval, but some are a little bit irregular and heterogeneous. So there is some overlap. When the lesion is atypical, we have to go for biopsy. We should not say this is still, it can be fibroadenoma. No, if it is atypical, go upgrade to BIRAT 4 and recommend biopsy. What are the morphological features of this mass? Shape and margins, what do you think?
Round shape.
Round,
Not parallel.
okay.
Not circumscribed.
Who said not circumscribed?
أنا ترتيب.
Why you said not circumscribed, Tertil? If it is not circumscribed, describe it more further. Which subgroup of non-circumscribed is?
لا غير لا هو circumscribed صراحة. I can I can see يعني well defined border between a lesion and surrounding parenchyma. So
okay.
it is
Okay, all of you, do you agree with her, all of you?
Yes, agree with her. Circumscribed margin.
Okay. Okay. This lesion in the literature described as regular shape, circumscribed margin, posterior acoustic enhancement, because maybe of round shape. They recommend biopsy. Okay, and it was great. I don't know. They reported as, in spite of that description, they reported as BIRAT 5. Okay, and it was grade 3 cancer. It was invasive ductal carcinoma. I don't know. This is on retrospect BIRAT 5 or based on what they reported as BIRAT 5. But for me, I'm not going, maybe I might say, yes, it may be rounded, but I have doubt about the margin. Okay. Do you remember, Suhair? We used to use the region of interest, to draw the region of interest.
Yes.
In our masses.
Yes.
When I draw the region of interest, look for this angular margin. It has an angular margin. So having an angular margin, it is not a regular shape. And now the features are fitting with being cancer. And some of triple negatives breast cancer are easy to be misdiagnosed as benign breast masses, especially for young patients. Okay. What are, as we mentioned on mammography and other lectures, we said that we have 1.4% circumscribed masses are malignant. Do you agree? Do you remember that?
Yes.
Okay. What is the differential diagnosis of that?
Medullary carcinoma.
Medullary, excellent.
Metastasis.
Metastasis, excellent.
A high-grade invasive ductal carcinoma.
High-grade invasive ductal carcinoma, excellent.
Mucinous carcinoma.
Mucinous and?
Papillary.
Excellent. And? Okay. Okay. So we have differential diagnosis, but the general features for the circumscribed masses are extremely cellular masses and usually associated with posterior enhancement features, okay? And may have high-grade lesions, okay? And associated with inflammatory reactions. Usually are positive on Doppler scanning. And as you mentioned, that include mucinous, medullary, papillary, phylloides, you forget phylloides, intramammary metastasis, high-grade ductal invasive cancer. And I think I have noticed in the literature also they mentioned that which one? Well, I don't know why I have lost it. The one arises in the parotid and salivary glands. Which one?
Adenoid cystic carcinoma.
What?
Adenoid cystic carcinoma.
I don't think. I don't remember. No. I will let you know. I'll search and I'll let you know later, inshallah. Next lecture, I will tell you about it. For Miyuko, or I don't know why it come to me and disappear. It is rare type of cancer, but they have mentioned that it's also part of this group of cancer. Okay, so if you look for this, as in the previous example, from the first glance here, you might say this is a circumscribed oval mass, this one. But when we zoom these lesions, you see, we can see the borders is not really. Look for this area here and look for this area, and even see there is thick hyperechoic. Okay, here, yes, here there is abrupt. Look anteriorly, there is abrupt. Here, because of the posterior shadowing, it might mixed, but at least there is no capsule. But not only that, look for these lobulations. Look for the lobulations. Look for the lobulations. Okay, look for these lobulations here. How many lobulations? And look for the hyperechogenicity. You might see here, this is away from the posterior enhancement. There is some hyperechoic rind or rim, and this lesion was proven to be a mucinous carcinoma, okay, from the literature. Okay, so we have to be cautious. When we look for these two lesions, what is the difference between the two? Okay, obviously here, both are oval, parallel, seems to be circumscribed. But here, it has a pseudocapsule. It has sharp, the margins are sharp. This it seems to be circumscribed, but does the margin is sharp here? It seems to be fuzzy. It's not very sharp. Not very sharp. So even circumscribed lesions can be like this, sharp, smooth margins, as seen here. This is unsharp. The margin is not sharp. So I'm not going to consider it as circumscribed in this case. And that was the mammography here. So also, it seemed to be indistinct. Borders here, only this sharp, but here was indistinct, and the case was a complex cystic lesions on ultrasounds, okay, with septation as we have seen here, but we were concentrating on the margins, and the biopsy revealed intracystic papillary carcinoma. See, papillary carcinoma is one of the group presenting as circumscribed. But when you look for the circumscribed masses and usually zoom these and carefully evaluate the margins, you might find that are not strictly circumscribed. Definitely not like this. There is a pseudocapsule here seen throughout like this one. Definitely, if you compare it with this one, look here, even look here, look here. You can see faintly hyperechogenic rind seen here. And here very indistinct at this area. Okay, again, if we look for this one, this it seemed to be more or less sharply demarcated, but look for this one. They reported also as circumscribed. It might tend to be fibroadenoma, but at the end, it is not a circumscribed. Why it is not circumscribed? Look for these margins. Look for these shagginess. These are speculations, and look for this part of the lesion here. Okay, even projecting from the contour. Here it is projecting from the contour. So this is uncircumscribed and this is sharply demarcated. Again, compare these two masses. It's obviously this circumscribed. Though I could not see the capsule throughout in this image, but I can see it at least anterior and posterior. Here it is more sharp, and here I cannot see any reactions, but I cannot see it well. I need to evaluate real time to make sure on the lateral aspect, but generally or roughly, it is circumscribed. But this is obviously, if it is anteriorly circumscribed, laterally and posteriorly, I cannot consider it circumscribed. Do you agree with me? Do you agree?
Yes.
Though
Yes.
it is oval parallel, so we have to be cautious because margins are really important, are primary predictor of to differentiate benign from malignant. Okay, what about this? Here, this is the margins.
Angular margin.
Excellent. This is angular margin. This is an angular margin. Angular margin also unique descriptors to ultrasound. It has a sharp corner of informing an acute angles. Okay. It is a highly suspicious. It is a highly suspicious. It is about BIRAD, positive predictive value in the range of 70. Within the BIRAD 4C. Okay. Okay. Breast cancer, as you know, is heterogeneous. One mass, one representing cancer, totally different from another one. There are a lot of variations in the presentation of breast masses representing breast cancer. But not only that, even within the same mass, within the same lesions, breast cancer is heterogeneous. You might find within the same lesions benign findings along with malignant findings. So this is not surprisingly to visualize a benign as well as a malignant features within a lesions. So you might see a lesions completely circumscribed except for small area. Okay, so that is why we have to be cautious. We have to look for the lesion throughout in at least 2 different perpendicular or orthogonal planes, and we have to sweep carefully throughout the margins looking for any subtle findings. If you look for this example here, it seemed to be circumscribed, but if I'm looking here to these portions, can you see it? You see, there is microlobulations and there is angular margin here. There is a focal area. And these lesions, if we go back, can you see? This is oval parallel, but the tissue plane, what happened for the tissue plane here? And what about the margins of the lesion here? So I have angular margin and there is cutoff of the tissue plane. The cutoff sign, do you remember the cutoff sign?
Yes, cutting sign.
Our sign, huh? So usually these angular margins represent invasions, okay, at a lower resistance portions. And as we mentioned that, usually on the lateral aspect, there is between the tissue plane, there is a lower resistance. So that is why usually at this location, the cancer infiltrating. And this one, the margin here, this is irregular, non-parallel, and these, the rim, look for the thickness within the same lesions. Here is thick, here is thinner, non-uniform, giving indistinct margins as well as these
Angular margin.
angular. These are angular margins. Okay, and here the margins. Okay, there are multiple small undulations. So this is microlobulation. Okay, the microlobulations also subgroup or subcategory of the non-circumscribed margin characterized by short cycle of undulations or small lobulations, about 1 to 2 millimeters along the surface, either partial or throughout the mass. These are my patients, proven to be breast cancers with microlobulations. As you know, it is suspicious features within the range of BIRAT 4C, and usually either represent fingers of invasions or introductal component, DCIS, or invasions part, the invasive cancer extend into the adjacent tissue. We have to differentiate it from macrolobulations, as in this fibroadenoma. Okay, this is my patient. From the first glance here, it gave impression that this is a macrolobulations, okay, and probably it is a fibroadenoma, but the lesions is not homogeneous and the margins are not so clear. I could not see a pseudo capsule. So when I angulate my probe and sweep throughout the margins, look for the undulations here. How many undulations you see? And the margins are not very sharp, not very clear. So because of heterogeneity of breast cancer that can be seen within the single lesion, a full margin evaluation of the margin evaluation of the mass is very important. And with a real-time assessment recommended, particularly for lesions that are indeterminate, okay? As in this case, you might look at the beginning and say this is a large or giant fibroadenoma or benign phylloides, something like that. It looks probably benign. No, we have to look and we have to take it serious, okay? And sweep throughout the margins, okay? And when we swept through the margins, we could appreciate these microlobulations. If we compare these two lesions, this is the lobulations here are small, micro, while these though are too numerous, but at macro. There is a literature that says high-grade cancer tend to be macrolobulated and lower grades tend to be microlobulated. Okay? What is the difference? This is the same lesions, okay? Examined by operator and repeated by an expert one. Can you see the difference? So we have to be cautious while scanning for the margins, okay? Looking for the margins, we have to sweep throughout. Yes, you might see part of the lesions, okay? One view of the lesions as circumscribed, but does the whole lesions, the whole margin is circumscribed or not? We have to look and make sure, because that lesion on mammography was suspicious. That is why they repeat the scan by another more expert operator, and they found, this is from literature, and they found that it is really suspicious lesions. These are invasive cancer. What about the margins? Here we can see alternating straight white and black lines representing speculated margins. This is my patients, you see. It's obvious speculations on mammography, and these are the speculations on ultrasounds. And more of which here seen as echogenic rim more than just very clear spicules could be resolved due to our machines. Okay. What is speculated margins? Subcategory of non-circumscribed, representing alternate hypo and hyper echoic sharp lines radiating perpendicular from the surface of masses, and is often features of malignancy with positive predictive value of 68% by Stefros et al. Okay, this is a high. The highest predictive value is the speculated margins along the descriptors. It is usually associated with a less cellular cancer or masses and low-grade cancer with desmoplastic reactions. And as you have seen here, usually having posterior shadowing because associated with desmoplastic and fibrosis, and correspondingly having no echoes on Doppler scanning. Again, more examples of speculated lesions. Okay, can you see these all hypoechoic lines within this hyperechogenicity? And again, here we can see some of these radiating lines. So it depends on the background tissue. The speculations are both hypo and hyper. Both are present, but it depends on background tissue. It might eliminate one and the other will appear. Okay, if we look for these two examples, and here we can see spicules, thin lines radiating because the surrounding tissue might be reactions whitish, but the surrounding are white. So some of these are ductal extension and some are thin are speculations. So appear as hypo because the surrounding is white tissue, as well as in the lower examples. You can see as these lines as hypo because the surrounding fibroglandular tissue. Eliminate the hyper. But in the other two examples here, especially for this one, the background fatty breast, that is why look for the long hyperechoic spicules extending in both sides of the lesions, and here some of which could be appreciated, while the others might be beyond the resolutions of the ultrasound, appear as just hyperechoic rind. This is a 3D, okay, ultrasound, and here we can see 1.5 centimeter invasive carcinoma, the circle, okay, annotations here. If you look carefully, you can see thin, very thin hypoechoic lines radiating from this. Here in zoom image, you might see it. So because there is surrounding fibroglandular parenchyma white, that is why we could appreciate the hypoechoic radiating spicules. In the other examples of the 3D, because the surrounding is fatty, so the spicules, most of which are echogenic, but between these we can see faintly some of hypoechoic. So in deliberate effort to harmonize with mammography, the mass morphologic descriptors. So we have, regarding the shape, we have regular shape, circular, and or rounded and oval, okay? And no more use lobular. And in the other hand, the irregular shape. Okay? And sorry, the oval, this is the irregular. The oval also involve or include the parallel oval lesions with macrolobulation or 2 or 3 undulations. And this is the irregular one. And regarding the margins, we have either circumscribed or non-circumscribed, which include indistinct, microlobulated, and speculated as on mammography. However, what is this? The partially obscure descriptors is unique for mammography, not used on ultrasound. And the angular descriptors is unique for ultrasound, not used on other modality. Okay, if we look here, these small lesions, microlobulated, non-parallel, malignant, these both are my case. But this is, I could see throughout, obviously, but this one, I can see part of the lesion, and due to extensive posterior shadowing, difficultly visualize the deep portion of which. So I used the convex probe, and here I could visualize the lesion. I eliminate this posterior shadowing and could see the deep portion of the lesion, and even the margin of the lesion here very clearly microlobulated, speculated, indistinct, or what we can see combined features of non-circumscribed margins. Okay, and as we have mentioned that we have to go throughout the margins. Here we can see the microlobulation. When we sweep, also we can see this area of angulations. Okay. Okay. So if I see here, if I look for this one, there is extensive shadowing, but there is a clue that this mass most likely malignant. Why? Because of the rim as well as overlying skin thickening. This is not a capsule. Only from this, okay, I can see that this is a suspicious mass. Not because of posterior shadowing, but because of the surrounding echogenic rim and the overlying skin thickening. And here again, when I used the curved transducer, I could visualize throughout and look the mass orientation, non-parallel, and look for the margin now, the shape irregular, and all malignant features. Okay, talking about the descriptors of echo pattern or internal echo pattern of the lesions. Okay, as we mentioned earlier, we said that the fat is the reference, the mammary fat is the reference for breast echogenicity. And we refer and we can correlate, okay, any lesions or the structures to the fats. And the echo pattern, okay, is also ultrasound specific descriptors. It is unique to ultrasound. Okay, so if a lesions have no internal echoes, then we call it as anechoic. And this is an extreme left of echogenicity scales. And if it is having increased echogenicity to the right of the scale, then we call it as hyperechoic. And most of hyperechoic lesions in the breast are fat-containing lesions, and usually it is more echogenic than the fat or equal to fibroglandular parenchyma. Okay, and most of which are benign, but still we have some hyperechoic malignancies. Isoechoic, when the lesions having the same echogenicity of the surrounding fat, which sometimes make the lesion relatively inconspicuous. When the lesions having less echogenicity relative to the fat, then we call it as hypoechoic, and this is the region where most of the breast pathology present, okay? Both benign as well as malignant. Complex cystic and solid mass is non-specific, contains both anechoic fluid and echogenic solid component. And heterogeneous lesions, there is a matrix of echogenic pattern within the tissue. And the area of concern for us, okay, usually from hypoechoic, complex, and heterogeneous. And here is obviously this lesion having the same echogenicity as the surrounding fat, while this, it is so brighter than the fat, hyperechoic, that is isoechoic, and here there is no echo. It is anechoic. This is lower than the fat, hypoechoic, and this having mixtures of echogenicity, hypo, hyper, and anechoic, and this is a heterogeneous echogenicity. If we look here, apart from this surrounding capsule, we could not appreciate that there is a mass because the echogenicity is more or less same as the adjacent fat. So this is an isoechoic mass, and usually lipoma representing such lesions. Okay, and here we have different examples of isoechoic with different pathology. Here I have 3 fibroadenomas, fat necrosis, and lipomas. Okay, so isoechoic non-specific for benign or malignant. Lipoma and fibroadenoma can appear as isoechoic. And this is my patients. Can you see these lesions having the same echogenicity as surrounding fat? Very subtle, but there is some non-circumscribed or some distortion here. You see an echogenic ring. This is the echogenic ring, make contrast, separating the margins from the surrounding tissue, and cut off signs, you see, all due to these indirect signs, okay, and the surrounding reaction make this cancer appreciated in ultrasound. Okay, so there are some malignant lesions, or not some. There is a good number of malignancy that appear as anisocoic lesions. Okay, so this is obviously more than the fat, hyperechoic in a case of angiolipoma. And here we can see silicon granuloma, fibroglandular tissue, 2 lipomas representing hyperechogenicity. Okay, so hyperechogenicity, if it is associated with circumscribed margins, okay, then it will have a negative predictive value of 100%. it will be lipoma. If it is circumscribed, okay? If we look for these examples here, although this is fibroglandular tissue in ectopic breast in the axilla, these cases, hyperechoic lesions, both are my patients. In these examples, fat necrosis, while this case, it was invasive cancer. Can you see the central hypoechoic needles? Usually, cancer, when you find a hyperechoic cancer, look for even tiny hypoechoic needles. Probably you might see it within the hyperechogenicity. Okay, so this is slightly less than the adjacent fat. This is a hypoechoic. Can you see it here? Near to the nipple, this is my patient's. And can you see, although it is benign, okay, circumscribed and everything, giving some effect into the adjacent skin pressure, like the pressure erosions. You see, this case, a chronic ductectasia with inspissated secretion. It was my case. So very long time, I have followed that patients and having the same stationary lesions. Okay, this is a hypoechoic benign mass. Okay, so these are examples of hypoechoic. Hypoechoic, as we mentioned, darker than the fat. Most benign and malignant lesion within this range: fibroadenoma, complex echogenic cyst, and most of the cancers are hypoechoic. So these my patients, 3 cancers, and these 3 hypoechoic fibroadenomas. Okay, so regarding the cancers, regarding the hypoechogenicity, the positive predictive value in the range of 4C. You see, unless the lesions is parallel oval with pseudocapsule, we cannot report it as BIRAD 3. We have to go directly to BIRAD 4. Here I have a hypoechoic, okay, lesions. Both are hypoechoic, but this is deeply hypoechoic and this is slightly hypoechoic with a high machines, high quality ultrasound machines. The frequency, bandwidths, and dynamic range have all been increased with offset the contrast resolutions. You see, this sometimes make the hypoechoic lesion appear iso or slightly hypoechoic rather than our old machine that showing all of the lesions as deeply hypoechoic. But we have to be cautious also regarding our technique. Why? If you look for this, you can say this is a cyst, but when you correlate it with ultrasound here, we have to make sure putting Doppler, it was vascular. That was it appeared anechoic mass due to technical fault of ultrasound. The sonographer presenting this mass as a cyst, but actually it was a suspicious hypoechoic mass proven to be invasive ductal carcinoma. If you look for the margin, for the shape, it seemed to be, it has some lobulations. And if you look for this border here, you can see some speculation and there is a rind here. So that was invasive cancer. And again, this less expert showing this cyst as indistinct hypoechoic mass. But when they repeat it here with good ultrasound setting, it was just a simple cyst. Okay, so this is obviously here an anechoic mass or cyst, and these are two anechoic masses. What do you think about both? Definitely this oval parallel circumscribed with pseudocapsule, okay, straightforward with posterior enhancement, straightforward simple cyst, like this one. But look for this one. Yes, it is anechoic, definitely anechoic with posterior enhancement, but it is irregular shape, non-circumscribed margin. That was my case and proven to be breast cancer. Okay? So what is the difference between this and the previous one? Here, there is cyst component, anechoic, but at the same time, there is an echogenic component within the cyst. So this is the complex cystic solid mass. And new descriptors in the 5th edition, not the 6th one. The 6th editions not yet seen, not yet, still not, we did not see it. But the 5th editions, okay, add this complex cystic and solid that composed or contain of fluid component, anechoic, and echogenic solid component. Okay, here we can see different examples of complex solid cystic and solid, which in the early, okay, the term of this lesion was a complex mass. In the 4th edition, the descriptor was a complex mass. In the 5th edition, they have changed it to a complex cystic and solid mass. The descriptor now is complex solid and cystic mass. As we mentioned, that composed of or contain of anechoic fluid that contain echogenic or solid component. The solid echogenic lesion, it can be thick wall, it can be nodule along the wall, okay, as seen in the classical papilloma or intracystic carcinoma, or it can be along the septum also, or thickened septum. And if we can see fine internal echoes, it will be suspicious for hemorrhage within these lesions. And this descriptor or this feature is suspicious for malignancy. And it is BI-RADS 4, and we have to recommend biopsy. This is intracystic papilloma, complex fibroadenoma, phylloides, fat necrosis, intracystic papillary carcinoma, and intracystic papilloma. So there are variations between benign and malignant, but at the end, it is the suspicious features, and we have to exclude malignancy. If you look for this, here we can see cystic component with fine internal echoes, but look for the septum. It is nodular, thick septum. So it is BI-RADS for biopsy. Compare it with this one. Look for the septum here is very thin. It is anechoic, it is clear, it is circumscribed with posterior enhancement. Both are with posterior enhancement since there is cystic component. But the difference in the septum, can you see the septum? This is thin septum. The septum here definitely is more than 5 millimeters, and it is nodular. So this is the case of encapsulated papillary carcinoma, and this is just a simple cyst. Here we can see another examples. Look for this cyst and for this septum. It is thick and it is vascular. So it reflects that this is a soft tissue component. So this is definitely complex solid cystic mass, and the case was a cystic papilloma. But at the end, it is suspicious. It has to be pathologically proven that this is my patients. So also complex cyst with solid component and it was proven to be a fat necrosis, okay? And this, a palpable abnormality in, I think this one, lactating woman, okay? And since she's lactating, that is the thick septum in a background fluid in a case of a galactocele. While in this case here, look for this one with posterior shadowing, complex lesions, but the patient having history of lumpectomy and features are going with fat necrosis, and it was proven by corresponding mammography. And this is a follow-up of complex cystic solid mass. It was more cystic, now become regressing in size and become more towards soft tissue, less cystic. So going with a history of hematoma, okay, being regressing, this is an organized hematoma. And this one, complex solid cystic lesions proven to be low-grade DCIS. What about these characters? This one, I have hypo, hyper, and a lot of mixtures of echogenicity. So this is heterogeneous echogenicity in a case of epidermoid cyst. So here I have different examples of heterogeneous echo pattern from benign to malignancy. What is heterogeneous echo pattern? It reflects a lesion having matrix inhomogeneity due to mixture of echogenic pattern. You might see any combine of the echogenicity either with hyper or with hypo or with anechoic and so forth. See, if you have seen all of these together or part of them together, it will give inhomogeneity of the background matrix, and this is indicating range of cell types, you see, and it has been also added in the 5th editions, and it has a little prognostic value, as we have seen here, from benign to malignancy. But at the end, since it is indeterminate, so it has to be within the range of BIRAT 4, and if the lesion is heterogeneous, we have to recommend biopsy. And even here, this is a heterogeneous fibroadenoma, and this is a hamartoma. This is an example of heterogeneous echo pattern, okay? Look for this heterogeneity in a case of mucinous carcinoma. Whenever you have seen hypo and hyper echogenicity, so you have to suggest biopsy to exclude malignancy. It will be more suspicious combination of. However, there is also within this group of hyper and hypo included the inflammatory lesions. These are my patients that was invasive cancer, and this one was granulomatous mastitis. Look how are similar, both are heterogeneous. So along with cancer, the inflammatory process within the breast can give heterogeneity of hypo and hyper echogenicity. And whenever the lesion heterogeneous with the fat component, it will suggest benignity, as in this case of typical hamartoma. Okay? So this is regarding echo pattern. Here, this is anechoic. Both are hypoechoic. One is fibroadenoma, the other was cancer, and this is hyperechoic. This is an isoechoic, heterogeneous echo pattern, and complex cystic and solid. Okay. And what about this one regarding echo pattern? It is heterogeneous here, and echoic, complex, isoechoic, hyperechoic, and hypoechoic. More examples. Anechoic, excellent.
complex cystic.
Excellent, complex cystic solid.
Heterogeneous.
Hypoechoic.
Hypoechoic.
Heterogeneous.
Yes, heterogeneous. And here is isoechoic. Which one is missing regarding the internal echo pattern?
Hyper.
Excellent, the hyperechoic. And here we have this one.
Hyper. Hyperechoic. Hypo. This is heterogeneous.
Heterogeneous. Which one? Which are missing?
Anechoic.
Complex.
Anechoic and complex. Excellent. Okay. So regarding the posterior features, okay, posterior features also a unique descriptors, specific ultrasound is specific. Okay, and it reflects what? It reflects. It is feature reflects the attenuation characteristic of the sound, okay, across the lesions. And still, it is non-specific, can be seen in benign and malignant. And breast cancer is equally can be presenting with posterior shadowing, with enhancement, without, or combined. So it is a non-specific features. Okay, so the choice previously called posterior acoustic features, but have been changed to posterior feature only. Now the descriptor since the 5th edition is posterior feature. No posterior feature or not affected, that means the area immediately behind the mass is not different from the surrounding tissue. It is the same than the surrounding tissue. There is neither posterior shadowing or enhancement. Enhancement, that means there is a column of more echogenic or wide deep to the mass. And the shadowing, there is attenuation of acoustic transmissions that appear as a central column, okay, that is darker deep to the mass. So posterior to the mass, there is black area due to sound attenuation, or we have a combined pattern, both, okay, attenuations and enhancement, or even part of which not affected. We're looking for this. There is no difference in the posterior to the mass from the surrounding tissue. So this is unaffected or no posterior features. Again, looking for these examples here, I cannot see any changes posterior to the lesions. So this is one not affected, no enhancement or shadowing. What about this one? Can you see any change here? If there is faint, you see, increased echogenicity, column of increased echogenicity posterior to this cyst. So this is enhancement. And here intense bright column posterior to this simple cyst. And again, here there is bright column posterior, but not as intense as in this one. I can see the tissue through this white column, and look here, the white column, okay, following the contour of the mass, okay. Usually when we see with the soft tissue mass posterior enhancement, usually it reflect what?
Cellularity.
High cellularity. As in this example here, can you see the posterior enhancement in this and some slight heterogeneity, okay. And we have seen it before, this mass. So this is the mucinous carcinoma. Usually with mucinous carcinoma, we have seen posterior enhancement. Okay. So this is my patients. Okay, these are my patients. Demonstrate posterior enhancement. This is a fibroadenoma, and this is a carcinoma. This is a simple cyst. Is expected. It is a feature of the simple cyst to have a posterior enhancement. But when we have seen it with a soft tissue, that most likely indicate a high cellularity or high-grade carcinoma, okay? And it can be seen with metastasis in the breast and metastatic axillary lymph node, and it is a non-specific feature, but it depends upon the other features, okay? If it is associated with typical fibroadenoma or a cyst, it's okay. But if there is any associated indeterminate or suspicious features, we have to go for biopsy. What about this here? I can see a column of black or dark echogenicity posterior to the lesion in a case of a posterior shadowing or acoustic shadowing, okay? And it can also the same as the enhancement. It can be intense, as in this example, or it can be faint, as in this example. It can be seen along the contour, or it can be seen as part. And as we said, it is not non-specific, but it has about positive predictive value of about 50%. So it is within the range of BIRAT 4B, okay? Can be associated with fat necrosis, with stromal fibrosis, okay? So this is my patients. Look for how this lesion, this mass, demonstrate intense posterior shadowing. When I use the convex probe, I could evaluate the mass and eliminate this posterior shadowing. Also, posterior shadowing can be seen in association with macro calcification at these parenchymal calcifications. Okay, and here, this is 3 examples of fibrosis. Fibrosis associated with underlying carcinoma, but these examples of fibrosis not associated with underlying carcinoma, as in focal fibrosis in 32-year-old lady. Look how it's simulating cancer. So this is a mimicker, and the other mimics here is a diabetic mastopathy. Okay. This is only shadowing glandular tissue. It is difficult, but in my experience, I have seen such type of breast, and usually very challenging. But definitely, most of the parenchyma, it will be like this, and most of the time it will be bilateral. So just it will affect the sensitivity of the ultrasound study and evaluation, but being bilateral, involving the whole parenchyma, it is not going with the focal disease. If we look for this one, I can see some shadow area demonstrate shadowing, while the other one not affected. So this is a combined, and if I look here, I can see column of posterior shadowing, a column of posterior enhancement, and edge shadowing. Again, here I can see edge shadowing, not only at the lateral margin, but also from this undulation here, giving also edge shadowing. We call this refractive edge shadowing. Can be reduced by increased probe pressure. When you add more pressure, you can reduce this edge shadowing, okay? Or if you angulate the probe, you might just reduce it or eliminate it with a slight alteration in the patient position. And usually this edge shadowing seen with the benign lesions like fibroadenoma and cyst, but at the end giving what when there is, it will give just a combined pattern of posterior characters or posterior features. And here, look for this giving some shadowing, and at this portion giving some enhancement in this circumscribed oval mass. I think it was a fibroadenoma. So regarding the posterior feature, either not affected, no posterior features, or posterior shadowing, posterior enhancement, and the posterior enhancement can be faint or intense, as we mentioned. Again, posterior feature here. Okay, so in this case, so obviously, which one? Not affected. Here I can see shadowing and mixed with shadowing. And here I can see enhancement, okay? I can see enhancement. These are triple negative breast cancer, demonstrate posterior enhancement, highly cellular, high-grade lesions. Again, not affected, no features, shadowing, enhancement, and combined. Okay, so talking about the approach to masses on breast ultrasound, according to the ACR, we have to evaluate the morphology, shape, margins, orientations, echo textures, acoustic, posterior, sorry, should not be acoustic, should be only posterior features. And later we are going to talk about the classification and associated features, or associated feature related to the mass. Okay, we can go through quickly through some examples here, just to revise what we have discussed. Sorry, I have to, here it appears, it's also, I suppose not to show the answer. So what is the echo pattern here? It is seen that it is a complex cystic solid. So complex cystic and solid, there are both anechoic fluid and hyperechogenicity. So what is the echo pattern in this case?
Heterogeneous.
Heterogeneous. Excellent. Okay. This is a heterogeneous. It was a metaplastic carcinoma. Just the posterior feature.
Shadowing.
Shadowing.
Posterior shadowing.
Shadowing, excellent. What is the echo pattern?
ISO.
ISO echoing.
Sure, it is ISO.
Yes.
Heterogeneous.
Accepted heterogeneous, but it is slightly compared with the adjacent fat. Slightly.
Hyper.
Slightly hyper.
Hyper.
Slightly hyper. And this one?
Also
slightly hyper, yes. Okay. This is the benign mass. Can you tell the shape. What is the shape of this lesion? Huh?
Shape of
Irregular.
shape.
Who said irregular? Who said irregular?
Sarah.
Excellent, Sarah. Yes, excellent. Why you said irregular?
Because it have some angulation and
Yes, yes. According to Stavros, non-parallel mass should not be called as oval. Being a non-parallel, we cannot say this is an oval mass. Okay, so this is an irregular mass, just being non-parallel. Okay. What is the echo pattern here?
Heterogeneous.
Is it heterogeneous?
Hypoechoic.
What are these?
Could be cystic changes أو ممكن
Yeah, so you have cystic and solid. So this is complex cystic and solid mass. This is a juvenile fibroadenoma. Okay. What is the shape and margin?
irregular shape. Angular margin. أو combined margin.
Combined. Yes, it is angular. It is, I don't know why it is written here microlobulated, but it is an angular. It is non-circumscribed. You see, it's non-circumscribed. Most likely I brought a copy to correct it, yeah. But I forget. Non-circumscribed. Non-circumscribed. It's okay. Mainly angular. And even I have to, it's supposed to be PowerPoint. Okay. Okay. Posterior feature here.
Enhancement.
Excellent enhancement. So if we compare this with this one, this is intense enhancement, while this is faint posterior enhancement. Echo pattern.
No posterior feature.
Echo pattern.
heterogeneous.
No. Look,
ISO.
apart from, yes, this is ISO. Apart from this pseudo capsule, you cannot separate it from the adjacent fatty tissue. It is ISO. What is the echo button here?
Hyperechoic.
Who said hyper? Excellent. Well done. Well done. Amazing. Orientation.
Non-parallel.
Excellent number. What do you expect to be arise from this mass? Which
Posterior.
terminal?
Posterior.
Excellent posterior. Echo pattern.
Complex cystic solid.
Complex, excellent. Okay, it was infiltrating. And this echo pattern?
Also complex.
Also complex. This is metastatic squamous cell carcinoma from the lung. The orientation? Shape?
Irregular.
Excellent. What do you expect to the echo pattern?
Heterogeneous.
Excellent, heterogeneous. From which terminal duct do you expect roughly might arrive? Posterior. Excellent. Posterior. Excellent. Well done. Orientation?
Not parallel.
Not parallel. Excellent. Not parallel. Shape and margin.
Round shape.
Round, well
Circumscribed
defined.
margin.
Circumscribed.
Sorry, it has to be. I don't know what happened, yani. You see, sometimes it's been affected while, okay. Okay, we were here. Okay. Shape and margin.
Irregular shape.
Irregular, uncircumscribed.
Non-circumscribed. Which non-circumscribed?
Microlobulated.
Predominantly microlobulated with indistinct combined.
Indistinct margin, yeah.
Combined, like, but because, as you mentioned, predominantly microlobulated. Okay, shape and margins.
Irregular shape.
Irregular.
Shape irregular. Margin
Yes.
speculated.
Predominantly, yes, speculated. Excellent. Echo pattern.
Anechoic.
Complex.
Excellent. Who said complex? Well done.
Me. Suhair. Complex.
Amazing. Yes, yes, Suhair. Very good. Yes. It is complex. Why?
There is hyperechoic component.
Yes, there is a mural nodule. Hyperechoic mural nodule on background of cyst. So this is a complex, and it's confirmed to be ductal carcinoma. Okay, what about this one?
Complex.
Excellent, it's also complex. There is here, this is septum, and there is some material seen here. And look for the margins. Okay, that was also suspicious, was also cancer. Both are cancer. Okay. Shape, I don't know what happened. Why it changed? I don't know why. I don't know what happened. Sarah is here. Sarah Almak. She asked me to read Al-Baqarah before this lecture. But a lot of things, I don't know what happened. I prepare it, you see, with PowerPoint and not PowerPoint. I mean, this is animation. I have done the animations. I don't know why it came like this. Okay, what is the shape here?
Irregular shape.
Irregular margin.
Mixed microlobulation with indistinct.
And combined, yes, almost all are there. Lesion boundary. Excellent, well done. When we talk about boundary, is there thin pseudocapsule or rind, echogenic rind, or nothing is there? Okay, and orientation? Not parallel. Excellent. Now it is seen here. So shape irregular, margin combined, boundary thick, echogenic, orientation not parallel, echo pattern.
Hypoechoic.
Only
Hypo and hyper.
Yes,
Heterogeneous.
heterogeneous. Posterior, acoustic feature, posterior feature. Sorry for acoustic. It has to be removed. Posterior feature.
Posterior shadowing.
Shadowing
And enhancement.
Excellent, combined. So what do you expect histopathology?
invasive
ductal carcinoma.
Invasive carcinoma, excellent, yes. This one. Shape.
irregular.
Okay, but
Oval.
with this
Indistinct.
measurement, with these
Indistinct.
measurements, you can say,
Oval.
you can
Oval.
say oval. Yes, you can say, because the transverse dimension is larger, much
Than the
larger
anterior posterior.
than the anterior posterior, even. And it seemed to be 2 or more. Okay, so margins.
Indistinct.
Indistinct, non-circumscribed, mainly indistinct. Lesion boundary.
Thick echogenic rim.
I can see partial
Pseudocapsule.
capsule here, but it is not complete. Not complete. Orientation.
Parallel.
Parallel. Echo button.
Heterogeneous.
Very heterogeneous. This is heterogeneous. Okay. Predominantly hyper.
Hyper.
Okay. Heterogeneous, predominantly hyper, but there is hyper. Posterior feature.
Posterior shadowing.
Posterior shadowing.
Okay, shadowing. What do you expect histopathology?
Mucinous.
Excellent. It could be mucinous, but could it be benign?
Lipomatous lesion.
It can be benign, yes. Okay, it can be some contain lipoma or what else?
Angiolipoma.
What could it be?
Bash.
Excellent. Who said bash?
So here.
Well done, Suhair. It was the case, it is bash, okay? Was proven to be stromal hyperplasia, bash. Okay, shape. Quickly, يلا خلاص, it is clear now. Shape, huh?
Irregular.
Irregular. Margins.
Combined. Speculated, angular margin, microlobulated.
Okay, lesion boundary.
Thick echogenic rim.
Pseudocapsule partially seen.
No, not capsule. No capsule here. You cannot expect capsule with non-circumscribed margins, except if the lesions, it has partially circumscribed, partially not circumscribed. But if it is non-circumscribed throughout, you don't expect. If you have seen, even if it is thin hyperechoic, it is echogenic rim. Here it seems to be thin, as you have seen, but look at it here, how it is thick. And as we mentioned, it is non-uniform, usually thicker at the margins. The sides, I mean the sides of the lesion. Thicker at sides of the lesion. Anterior and posterior relatively thin than the sides of the lesion. But being, you have seen, yes, you have seen this hyperechogenicity. Here it seems to be, it's simulate, but it is not sharp as it is not sharp. It is not uniform. It is not thin. You see, it has variations. It is indistinct. It has variable thickness from here to here. Okay, so this is echogenic rim. Orientation.
Parallel.
Echo button.
Hypoechoic.
It is hypoechoic. Yes, excellent. Posterior acoustic feature.
Mixed.
Enhancement and shadow. Mixed.
Excellent. Mixed. Shape.
Irregular shape.
Irregular shape.
Excellent. Well done. Amazing. Margin.
Microlobulated.
With indistinct.
Okay, non-circumscribed, indistinct, microlobulated, accepted. Type. Okay. Boundary.
Thick echogenic rim.
Yes. Not throughout, but it is there. If you can see it here, you can see it here. Okay. Orientation.
Parallel.
Echo pattern.
Heterogeneous.
Heterogeneous hypo. Or
Isoechoic.
Predominantly isoechoic.
Iso.
Heterogeneous accepted, but it is isoechoic. Unless the surrounding reactions, it is difficult to be differentiated from the adjacent fat. Yeah.
Okay.
If you look for the fat here and fat here, you might suggest that unless you have seen this measurement and this some surrounding reaction, you might say this is part of the fatty parenchyma. Okay, so posterior feature.
Not affected.
Rudaina or whom is talking?
Yes.
Oh, Rudaina, welcome. Nice to hear your voice.
يديك العافية.
Okay. What do you expect the histopathology? You expect benign or malignant? And if you expect benign, what is your suggestion? If you expect malignant, what is your suggestion? With all these feature, combination of suspicious feature, still you suspect, apart from parallel orientation, there is nothing
Isoechoic.
supporting benignity, huh?
Isoechoic مش supporting benignity. أو يعني.
No, there are, I said, we have a considerable number of breast cancer presenting as isoechoic. Okay, might be third of the breast cancer are isoechoic. So if it is malignant, which one more in favor? Okay, it is mucinous. Okay, it was mucinous cancer. This is, you can compare this isoechoic and this isoechoic, but look for the lesion here, the complete pseudo capsules. Okay. What is the morphology, shape, and margins? Quickly.
Irregular shape, angular margin.
Again? Who said irregular margin? Who said irregular margin? Do you forget the cross? The cross on top of irregular? We said we should not describe the margin as irregular instead of non-circumscribed, because irregular is a descriptor of shape, not related at all to the margin. Do you remember that?
It's the irregular shape in distinct margin.
Excellent. Irregular shape, but the margin, is it indistinct?
Angular, accept.
Angular.
Excellent. Well done. You have seen the angular margin. So it is focal, but it is angular. Okay. So shape, quickly.
Irregular shape.
Irregular shape, orientation.
Number error.
Margin.
Non-circumscribed, angular.
Angular, yes, indistinct and angular. Ecotexture.
Deeply hypoechoic.
Excellent. Posterior feature.
Mixed.
Combined.
Enhancement and posterior shadowing.
I didn't see shadowing obvious, but I can see the posterior enhancement. Okay, to summarize this discussion, ultrasound is used to identify and characterize masses, breast masses, and to guide percutaneous biopsy when indicated. Standardize the term used for characterizing and reporting lesions. The BI-RAD lexicons has significantly improved the ability to communicate with commonly understood terminology that minimizes the risk for interpretive communication or management errors. So, breast imaging lexicons, ultrasound is strongly recommended. ACR BI-RADS ultrasound provides terms that describe the following features or findings on breast ultrasound examinations, which include shape, orientation, margins, boundary, echo pattern, posterior features, and some other we are going to discuss in the following lectures. Okay, the descriptors, orientation, echo pattern, and posterior features are ultrasound specific are unique ultrasound descriptors. These are all secondary to the shape and margin. In prediction, the likelihood for malignancy are not a primary per se. We cannot depend on this, but we use to combine these features along with the shape and margin. Each alone has little specificity and should not be used as a sole feature in assessing a mass for the likelihood of cancer. An abrupt transition zone between the lesion and the normal tissue is usually benign. An anechoic halo or rim around the lesion is highly suggestive of malignancy. A full margin evaluation is important with real-time assessment. The margin should be fully characterized, particularly for indeterminate lesions, and any portion of the margin is not circumscribed, the mass should be categorized as non-circumscribed. Thank you very much for your patience and attention, and I hope I was beneficial to you. And if you have any question, you are welcome. I'm here to answer you.
I have a question about the echo pattern.
Who is talking first?
Sarah Sam.
You are welcome, Sarah Isam.
Okay, while the normal fat echogenicity of the breast is grayish, and the lipomatous lesion tend more to be hyperechoic, because this is fat and this is fat.
Yes. It is a good question. Really good questions. Yeah. It is the same like in the other part of the body. Okay, the lesions, lipoma in the other part of the body are hyperechoic. Do you agree with me? As well as in the breast. But the strange one is the normal breast fat is relatively hypoechoic. And usually we adjust because the fat in the breast, okay, is available in all type of the breast. If the breast is fatty, if the breast is extremely fibroglandular and almost full of fibroglandular parenchyma with positive fat, still you can see thin layer of subcutaneous fat present in each breast. Okay, that is why they consider the fat in the breast to be the frame of reference of echogenicity. And the breast ultrasound has to be adjusted to put the fat in the breast at level of mid-grade. Okay? So as it will be easy to refer other part of the breast tissue or any lesion to the fat. I hope I can answer your questions. Otherwise, we can search about that. If there is any more information, we can discuss it later.
Okay.
Any of you having any suggestion for that? What I know that the fat, the normal fat in the breast is different from the normal fat in the body of in the rest of the body, but the lesions are the same. You see, because the lipoma everywhere it is iso or hyper. Do you agree with that? Fat containing are hyperechoic everywhere. Huh? Any more question?
أيوة بس عندي question.
You are welcome, Rudaina.
يديك العافية بس. طيب بالنسبة إذا في patient يعني عندها previous surgery ولا في lesion deeply hypoechoic لكن ما في كده يعني lesion mass بنقدر نمسك كأنها radial scar صغيرة جدا. فالnext step for this patient شنو المفروض نعمل؟
Okay. At what time? As
Okay.
post-surgery.
3 months. كانت 3 months تقريبا.
Immediate post-surgery or 3 months post-surgery? Okay.
3 months.
You are talking about ultrasound findings.
أيوة في الالتراساوند.
That was the baseline or you have a baseline ultrasound?
لا ما عندها كان أول حاجة بعد الإمبلانت يعني follow up.
The surgery was implant.
Yes.
So not cancer.
لا ما عندها كانسر لا.
Yeah, it is important. You said post-surgery. So post-surgery, this is important. If it was lumpectomy for malignant lesions or lumpectomy of benign lesion or for mammoplasty or implant, all these, it will affect your differential diagnosis. Here it will come first in the differential diagnosis, fat necrosis. Considering the history, okay, because most likely within 3 months, okay, she have to have. I mean, she must have baseline imaging pre-implant. خلاص? Okay. But might not be available, but at least she might have a mammography. So that means before 3 months, she has no suspicious lesion. And this a new lesion. What was the measurement of that lesion?
كانت صغيرة around يعني هي بس vertical زي خط vertical يعني around 1 centimeter.
The relation to scar site.
في نفس السكار سايت لكن not reaching the skin.
Okay, so it can be scar. It can be scar. It can be fat necrosis related to the scar. Okay, just if how old is she?
She's young with no risk factor. 32.
32. Okay, just follow. Give her follow up after 6 months, and that is it. That is the next. So just fat necrosis. Her history is suggesting a fat necrosis. and being was up most likely, okay, before 3 months, she had mammography or any imaging, and most likely she had no suspicious. That is why they proceed for surgery. So in such case, fat necrosis on top of differential diagnosis, especially it is related to the site of scarring, just for follow-up. Okay?
Okay, thank you.
No, thanks for my duties, my dear. Huh? Do you have any more questions? If you have no more questions, thank you very much. We can stop recording.